Let me move on to introducing our speaker for today. It is my absolute pleasure to introduce you to Dr. Tanya Jenkins, an assistant professor of sociology at UNC who studies how and why status hierarchies are produced and reproduced in the medical profession and how they impact both doctors and patients. In addition to her academic appointment in the Department of Sociology, Dr. Jenkins is the faculty research fellow at UNC's Cecil G. Sheps Center for Health Services Research and the book review editor at Social Forces. After earning her PhD in sociology from Brown University in 2016, Dr. Jenkins worked as a Canadian Institutes of Health research postdoc at the University of Chicago and was an assistant professor at Temple University. She joined the faculty here at UNC in 2019, at which point I was fortunate enough to meet her for the first time at some of the new faculty events organized by the Institute for Arts and Humanities, and I've since come to learn more about her research and come to admire it. Her talk today will focus on research that she did for her new book, Doctor's Orders, The Making of Status Hierarchies, an Elite Profession, and I'll hold it up for everyone to see its beautiful cover and a wonderful book. In the book, Dr. Jenkins draws on nearly 2 years of ethnographic fieldwork and interviews to compare two internal medicine residency training programs, one at an academic medical center and another at a community hospital. In it, she tells the story of how US residency programs have come to rely on international medical graduates and graduates of osteopathic medical schools, all while excluding those very graduates from top-tier residency programs. The resulting segregated programs, she argues, offer unequal training that impacts both doctors and patients. After reading portions of the book with my students in a health humanities course that I'm teaching this semester, I can attest that Dr. Jenkins' book is full of absorbing vignettes from the wards and compelling analysis of the intricate differences in the training provided by these two programs and the implications of this ongoing stratification on medical care. Her work will be of interest to future clinicians, like many of the UNC students joining us this afternoon, those of us who educate and train them, and everyone who will receive care from them. So please join me in welcoming Dr. Tanya Jenkins to Health Humanities Grand Rounds.
Thank you so much, Professor Weed. Thank you so much for that really warm welcome, and thank you all for being here today. Of course, I wish we could be meeting in person, but I think it's still just a wonderful opportunity to be able to share my research from my new book and give you a sense of some of the findings that Dr. Weed was just referring to a moment ago. So I'm going to go ahead and share my screen in hopes of you being able to see my title slide. Yeah, everything good? All right, excellent. Always good to get to do a check before we launch into a talk. So as Professor Weed mentioned, I'm going to be talking to you today about my first book. It just came out in July of this year. It's called Doctor's Orders, The Making of Status Hierarchies in an Elite Profession. And my publisher, I think, has contractually required me to mention that it is available for purchase on their website. But there is a 30% coupon if you're interested. So you can use code CUP at checkout at cup.columbia.edu. But the main takeaway that I'm going to leave you with today is that internal medicine residents are stratified and segregated in ways that might matter not only for themselves, not only for their education and their future mobility, but also potentially for patients. And I thought I would start out with a little bit of background information about medical education in the US. Some of this might be very familiar to some of you, while for others, this might actually be a sort of a new topic for them to delve into. So you may or may not be aware that it's been since the advent of modern residency training, so since about 1950, that the US has had to rely on international and osteopathic medical graduates, or what I collectively call non-US MDs. to fill postgraduate residency positions in the United States. They filled anywhere between 20 and 45% of positions because there are simply not enough American trained MDs graduating every year, or US MDs as I call them. We can see on these two graphs, the bottom line in both graphs are the number of US MDs graduating on any given year, and the top line are the number of residency positions available. And as you can tell, there has been that gap dating all the way back to the 1950s. And just to make sure we're all on the same page, residency is that required stage of training that comes after 4 years of medical school here in the US. It can last anywhere between 3 or 7 years, depending on the subspecialty. And so as you can tell, there simply aren't enough US graduates to fill all of these residency training positions. Now, to give you a sense of just how many non-US MDs we're talking about, this table shows placement results for first-year residency positions in 2019 for all specialties. So at the top, we have graduating US MD seniors who filled actually just under 60% of all positions across the country, despite the fact that around 94% of them ended up getting a residency position or matching. These are the match rates over here on the right. Those match rates decreased considerably as we go down the line for non-US MDs. And so these include osteopathic doctors, or DOs, who are US citizens who study osteopathic medicine in the United States. Now, their training is very similar, some would say virtually identical to MDs. They have an additional 200 hours of musculoskeletal manipulation training. And while DOs are, of course, American trained physicians, they're often treated similarly to international medical graduates by the profession because they took a non-traditional path of entry to medical school, which is why I'm grouping them into this heterogeneous group of non-US MDs. Next, we have US international medical graduates. These are US citizens who study medicine abroad, often but not exclusively in the Caribbean, and then come to the US to complete their residency training. And then finally, we have international medical graduates. These are non-US citizens who train abroad and come to the US for their residency training. And as we can tell from these match rates over on the right, there are large numbers of non-US MD applicants who apply to residency but don't end up getting a position. And that suggests that those who do match are a cut above the rest. And there's actually some data supporting that. So first, on average, the United States Medical Licensing Step 1 exam scores. Now, this is one of the biggest predictors of residency placement. It's one of the most important exams that medical students take. That on average, the exam scores are virtually identical between matched US MDs and at least international medical graduates in internal medicine, which is the specialty with the most number of spots. In fact, non-US citizen international medical graduates actually outperform all the US citizens on this exam, including US MDs, US IMGs, and DOs on step 1. And furthermore, for the same test scores, international and osteopathic medical graduates generally have a much lower probability of matching to their preferred specialty than US MDs. So in 2014, for example, in internal medicine, non-US MDs, which are referred to as independent applicants over here in green on this slide, they had to score 60 points or 3 standard deviations higher than US MDs on the same United States Medical Licensing Step 1 exam to have the same 80% probability of matching to their preferred specialty of internal medicine. Now, to give you a sense, a score of 250 over here on step 1 is roughly in the 85th percentile for this exam, while a score of 190, which is what's required for a USMD to have an 80% probability of matching, is in the 4th percentile for this exam. So clearly for the same scores, non-USMDs generally have a much lower probability of matching than USMDs. And yet non-USMDs don't end up typically matching to the same kinds of programs as USMDs. So within specialties like internal medicine, USMDs tend to congregate in highly prestigious programs, oftentimes in university hospital settings. These are usually programs that have more resources, that are better staffed. Whereas on the other hand, non-USMDs tend to congregate in so-called DO or IMG friendly programs, as they're called on the blogosphere. And these tend to be in smaller community hospitals with fewer resources. They tend to be in more rural areas, not exclusively, but oftentimes. And to give you a sense of just how widespread this segregation is across the country, along with some colleagues of mine, including a then undergraduate, now graduate student of mine, Grace Franklin, we worked to kind of to take a look at the landscape of graduate medical education in internal medicine across the country. And we found that 37% of all university-based internal medicine residency programs staffed 90% or more USMDs. So these are the programs over here on the right in red. These are university programs, and 37% of them staff 90% or more USMDs. And then over here in the blue, we found that 51% of all community programs staff less than 10% USMDs. So actually the exceptions are these integrated programs over here in the middle that staff roughly equal numbers of USMDs and non-USMDs. And if you're curious, this is where UNC Chapel Hill's program lines up in this histogram. At least that was the case in 2017 when this data was collected. It is a program with around 94% USMDs. And perhaps more disconcertingly, we found that USMD-dominated programs have significantly higher board pass rates. These are board exams that are taken at the end of residency. They have significantly higher board pass rates than IMG or DO-dominated programs, which is puzzling, especially because of those figures I mentioned at the outset, where especially IMGs tend to outscore USMDs on these standardized exams. So the larger questions at the center of my book, Doctor's Orders, include how do international and osteopathic medical graduates end up so marginalized in the American medical profession, despite the fact that the US imports some of the world's best and brightest? Why are programs so segregated on the basis of medical training background? And how does that segregation affect the residents' training and mobility within the profession moving forward more broadly? For today's talk, the question that I'm going to focus on examines the possible effects of this segregation on the residents' training to help unpack a little bit that finding that I just mentioned a moment ago, which was that IMG concentrated programs tend to have lower board pass rates than USMD dominated programs, despite the fact that IMGs come in with equal or sometimes even better average test scores than USMDs do. And the reason this is important is that not only does the US rely on non-USMDs during residency to fill gaps in healthcare, but even after they graduate, non-USMDs tend to staff positions in underserved, lower socioeconomic status, non-white communities. So we need to understand how their training might differ from USMDs in these university hospitals. And surprisingly little is known about whether training is comparable between these two types of settings. So at least within medical sociology, traditionally, sociologists have conceptualized medical education as being relatively standardized, relatively homogeneous across the profession, in part because of the importance of standardized education for strengthening medicine's autonomy. This is actually the professional dominance perspective put forth by Elliot Friedson and others. Now, according to professional dominance theory, one way that medicine has convinced society that it ought to be autonomous and self-regulating as a profession is by establishing not only that doctors have specialized esoteric knowledge that nobody else has, but also that they teach that knowledge at the same high level of quality everywhere. Standardized training was also especially important historically for professional medicine to distinguish itself from other practitioners, quacks, charlatans, etc. And standardization continues to be a very important priority of modern day regulatory bodies like the Accreditation Council for Graduate Medical Education and the Liaison Committee for Medical Education, which set out standards for graduate and undergraduate medical education, respectively. Now, this illusion of homogeneity or standardization in medical education is especially salient in previous studies that are examining the development of professional autonomy. So there have been several classic hospital ethnographies or studies of hospitals that have explored how student doctors learn to practice independently and safely, given the life and death nature of medical work. But these studies have primarily examined the process of gaining independence in primarily elite university hospitals. And as a result, perhaps unsurprisingly, they found very consistent results, which is that supervising physicians typically only give trainees as much autonomy as is safe for patients, given their demonstrated level of competence. Yet there's good reason to believe that approaches to autonomy and supervision might vary by training setting. So over 2/3 of medical residency programs are currently housed in community hospitals. And we know from the medical education literature that resources, including supervisory structures, can vary between community and university hospitals. What we don't know is how these differences can impact the residents' education, particularly non-USMD's education, which until now have been very rarely studied in this way. So in this talk, I challenge this assumption of homogeneity or standardization within medical education by comparing how training practices can foster different approaches to autonomy in a community and university hospital, affecting both the residents' training as well as patient care. And I'll be specifically focusing on 3 areas of the residents' work: their clinical reasoning, patient communication, and approaches to patient care. Now, this research question requires a research method that is well suited to understanding the intricacies of daily life in these 2 residency programs. And ethnography is ideal for this purpose. So I conducted a comparative ethnography of 2 internal medicine residency programs in the Northeastern United States. The first was a so-called IMG or DO-friendly program, as I mentioned, housed in a community hospital, which for today I'll creatively refer to as community hospital for our purposes. I give it a different pseudonym in the book, but to just not confuse people, let's just call it community hospital. And this was a program with a 90% non-USMD house staff. House staff is just a collective term for residents. The other 10% of the residents were USMDs, but these were trainees in a preliminary program. They were called preliminary interns, where they were spending 1 year at community hospital doing some medical training and then going on to more specialized residency programs in things like radiology and anesthesiology. The rest of the house staff were doing the full 3-year internal medicine training program. And about half of them were US IMGs, these were US citizen international medical graduates, while another 10% were DOs. So all told, about 70% of the house staff at community were US citizens. The other 30% were non-US citizen international medical graduates, some of whom had fully trained as physicians in their home countries prior to coming to the US and starting their residency training all over again. The second hospital was an elite program housed in an academic medical center. I creatively call it University Hospital, and it staffed almost exclusively USMDs. It's worth noting University Hospital was a safety net hospital, which meant that it was specifically designated in the state to accept individuals without insurance. Now, these hospitals had significant differences, namely in their supervisory structures. And those differences stem partly from differences in the resources available to both hospitals. Community hospital was so resource depleted that during my fieldwork, it was bought out by a holdings company, changing the hospital from a nonprofit to for-profit status. The hospital didn't have an electronic medical record at the time of my fieldwork. This was in 2013. So all charting was done using old-fashioned pen and paper. There were, with few exceptions, because of budgeting constraints, the attending physicians or the attendings of record that were responsible legally primarily for patient care They tended to be community-based primary care practitioners who admitted their own patients from private practice, from the office, rather than hospital-based attending physicians who spent all of their time, their whole day in the hospital. Now, by comparison, University Hospital was a much more resource-rich institution with dedicated teaching attendings who spent most of the day in the hospital and saw every patient with the team of residents. Now, despite these glaring differences, university and community had two important things in common. The first is that they both had a clinical rather than a research focus to their training programs. And the second is that they both produced residents that went on to go into both generalist and specialist careers, meaning that these programs represented neither the very top nor the very bottom of residency programs, while still sitting on different ends of the prestige spectrum. So I spent 23 months over the course of 3 years studying these two programs intensively. And during that time, I used various qualitative methods which allowed me to triangulate my findings. This included participant observation, where I observed teams of residents during rounds, during patient admissions, during emergencies, during lunch, even spending a lot of downtime with them in the residence lounge. I also did in-depth interviews with 123 respondents, which included residents, attendings, and program administrators. And then I also did some focus groups with some of the residents. Just a brief word about my analysis process. I did a preliminary analysis of the data as they were transcribed, which then allowed me to sort of use those insights to inform future rounds of data collection. I used NVivo10 data analysis software to systematically analyze the data line by line using open coding, and then that resulted in about 200 codes, and then I refined those codes using more focused coding. So what were my findings? I found that these two settings fostered two very different kinds of autonomy in the residents. And I define autonomy as the ability to practice independently as clinicians, which of course we expect our residents to be able to do before they graduate or by the time they graduate. Now, to illustrate this, I want to start out with two brief anecdotes from morning rounds at both hospitals. At Community Hospital, rounds usually consisted of a very brief meeting where the intern, which is a word for a first-year resident, the intern would update her upper year resident on the overnight events and new orders requested by the attending. And this meant that residents would often just read the note, the attending's note in the chart to know what the plan of action for the day was, rather than formulating their own plan. So for example, one morning, an intern announced to his resident, Raul, that their attending wanted to send a patient with a skin infection home on vancomycin, which is a very powerful antibiotic. Raul, the resident, however, disagreed with his attending, saying, quote, "I wouldn't do that. I would discharge her on something else." Now, this predicament, disagreeing with one's attending, while common for the house staff, was unfamiliar to a new medical student on the team who asked, quote, "What do you do in those situations? Would you override that attending?" And Raul replied, "No, because it's their patient. Same as you respect the patient's wishes, we respect theirs. They're responsible legally for the patients." So while of course it is true that the attending physicians were legally responsible for the patients, as is true in all teaching hospitals, they also weren't around much for the residents to engage with them and discuss treatment plans like this one. The main form of communication with the attending physician was through the paper chart and on the telephone. As one program administrator from Community Hospital explained, quote, "A lot of private attendings will come in at 5 in the morning, see their patient, write a note which you can't read, and you'll just follow up and call the attending, and that's your interaction. So what's the value in that? To me, none. You're becoming a robot responding to something written in a chart," end quote. So the lack of supervision at Community Hospital was due more to limited time and resources than any sort of calculated decision about cultivating the residents' independence, which you may recall was actually what other medical sociologists had previously found in their research. Now, interestingly, community residents often viewed themselves as autonomous, as very autonomous, because they were on their own a lot. But absentee attendings often meant that their clinical independence was actually curtailed, especially when it involved simply implementing orders. At the same time, residents were also regularly expected to make important clinical decisions by themselves without supervision. I therefore call this arrangement inconsistent autonomy, an experience of autonomy that would swing variously between non-existent and maximal in the same day, or sometimes even the same hour, and characterized by a common thread, being alone. Put together, the lack of resources at community hospital meant that residents were primarily viewed as laborers whose job it was to get the job done first, and trainees second. Now, in contrast, consider this example from the first day of a new month of rounds at University Hospital. The attending physician, Dr. Katz, sat down with his team, looked over at Nick, his resident, and said, quote, "I would never hope or dream of getting in Nick's way. He'll be leading things, but I like to be kept informed. Specific expectation number 1, I expect to be made aware of a deterioration in a patient's status, no matter what time it is. I don't think I've gotten a call after 7 p.m. that hasn't started with, sorry to bother you, but you're not bothering me. I'd rather find out about it at 2 a.m. than the next morning," end quote. So compared to community hospital, rounds at university were much more structured, much more hierarchical, but they had clearly articulated expectations in this way. And as will become clearer, despite having more supervision, the residents at University Hospital actually had more autonomy than the residents at community hospital. Now, I call this arrangement supported autonomy, such that subordinates could make their own decisions, but were always buttressed by layers of supervision, allowing them to gain independence safely without posing a risk to patients. This made the house staff much more like trainees than workers. So let's see how these different kinds of autonomy impacted the residents and their patients in these 3 different areas, starting with clinical reasoning. And because they rarely interacted with their attending physicians, community residents often described having to guess or divine their attendings' rationales for decisions, which had an impact on their own clinical reasoning. So one morning, for example, Spencer, an intern, updated Cy, his 3rd-year resident, on an anemic patient's hemoglobin level, which was 8.5. Now, the norm for a male patient is between 12.4 and 14.9. Now, the intern asked his resident, Cy, whether the patient could go home since he seemed to be doing better. And Cy shook his head, saying no. Quote, "The attending is going to go for the number, so let's give him above a 9. Let's give him another unit of blood," end quote. So in this case, rather than relying on his own clinical judgment to decide whether the patient was symptomatic and thus in need of a blood transfusion, which is actually what the national guidelines recommend, this 3rd-year resident, who was just a few months away from graduating from residency, instead emphasized making his attending happy. Now, of course, without seeing the patient for themselves, it's perhaps understandable that the attending would, quote, "go for the number" in this way. But this did little to advance the resident's education or reinforce evidence-based practice, to say nothing of the added risk of yet another blood transfusion to the patient. Now, in contrast, at University Hospital, attendings would always tell their residents transfuse symptoms, not a number. And if the residents did choose to transfuse, they were encouraged and often required to use scientific evidence to back up that decision. In contrast, at community hospital, decisions or discussions about evidence-based medicine were far less common and were less used in debates with attendings, in part because the attendings were rarely there to debate with. Now, to be sure, there were moments when community residents would find ways to work around their attendings, when they felt something was really necessary for a patient. Like once a resident instructed her intern to call the attending saying, quote, "Don't ask for permission, tell him we'll prep the patient for a colonoscopy," end quote. Also, different attendings had different expectations of the residents, making it difficult sometimes to know how much initiative to take. Some attendings would become furious when the house staff would make decisions without consulting them. Other attendings would become furious when they were over-consulted for decisions. So perhaps unsurprisingly then, aside from basic management decisions like replenishing fluids and controlling or managing diabetes, community residents often preferred to wait for attendings' orders before making their own treatment decisions. Take Faisal here, for example, who told me, quote, "By the end of third year, how will you make those decisions if you've never been trained to make those decisions?" I remember my first day here as an intern, we started on call. I had a patient come in with dehydration, hypernatremia, and pneumonia. So sitting with the resident, I said, "I think we need to do 1, 2, 3, 4. Are you okay with this plan?" And his resident responded, "Oh, I don't know, just call the attending." And so Faisal tells me, that doesn't make any sense. Why is there a resident carrying the patient with me if he can't make a single decision? So in Faisal's own words, inconsistent autonomy had an important impact on the residents' development as future physicians because they had so little experience developing their own independent clinical reasoning during training. Now, in contrast, because of the team structure at University Hospital, the residents there were empowered and expected to make independent decisions for their patients in consultation with, rather than under the thumb of their attending physicians. Now, for example, one morning an intern was discussing a patient with uncontrolled high blood pressure when she asked her attending, "Want to change his blood pressure meds? We have a lot of room to grow and a lot of medications, so you tell me what you want." Now, this sort of deference to attending's wishes, which was very common and expected at community hospital, was absolutely unacceptable at University Hospital. In response, the attending replied, "Excuse me? No, tell me what you want. We're your training wheels," referring to he and the resident. So interns at University Hospital were thus expected to take independent decisions that could be corrected or debated or outright wrong, but independent nonetheless, rather than simply deferring to whatever their attending wanted. Now, beyond affecting their clinical reasoning, the lack of supervision and role modeling at community hospital also had an impact on the way the residents communicated with their patients. One morning, for example, Terry, a third-year resident at community hospital, went to talk to a patient about her diagnosis. And so he comes to the bedside and he says to her, quote, "So you did bleed, obviously, because of your coffee ground emesis." Now, the patient had no idea what that meant, and so just responded with a blank stare. And Terry continued, "But your hemoglobin is normal." Another blank stare. Now, of course, what Terry was trying to say was that the patient had vomited blood, but that her blood levels appeared normal, suggesting that the bleeding in her digestive tract had stopped. Now, if an attending had been present at the bedside, he or she could have clarified the jargon for the patient and, of course, reminded Terry, the resident, to avoid using such technical terminology with patients. At University Hospital, residents, in contrast, would receive regular feedback and would certainly benefit from regularly observing their attendings during rounds. And so they tended to be much better communicators on average than the residents at community hospital. This role modeling would often rub off on the residents, who made it a priority to speak to patients in lay terms, avoiding jargon whenever possible. And when they did use jargon, the attendings were there to step in if necessary. So in one example, Blake, an intern, and Louise, an attending, went to see a patient whose heart failure was so severe, they were concerned that she wasn't going to pull through. There'd been talk of sending her to the coronary care unit, or CCU. And so Blake begins to tell the patient and her daughter that, quote, "We may send her to the step-down unit or CCU." And what he meant to say was that the patient might either be sent to the intermediate coronary care unit, which is a step up from the general wards, or the full CCU, which is the highest level of care. But he didn't explain what these terms meant. You could tell from the face, the daughter's expression, that she was confused by what he was saying. And he didn't explain what the difference was between these two possible outcomes. So Louise, the attending, stepped forward very gently and took over the conversation, starting from the beginning. These two examples of Blake and Terry highlight the fact that trainees of all kinds can struggle with patient communication. The difference here was that at University Hospital, there was an attending regularly present, an educator regularly present to correct trainees and protect patients. Now, some might point out that because the residents at Community Hospital were non-US MDs, that they might not have been used to American cultural standards of patient communication, avoiding technical jargon, that sort of thing. But remember that University Hospital residents use jargon too, in the case of Blake just now. And in the previous example with Terry, he was actually a US citizen, international medical graduate, who was now nearing the end of his 3-year residency at an American hospital. So the biggest difference between these two examples wasn't cultural, but rather structural in terms of the supervisory structures in place. And finally, in terms of how all of this affected approaches to patient care, the absence of attendings at Community also meant that residents were often left to their own devices to make in-the-moment treatment decisions without much support. Now, to be sure, some residents really liked having this much freedom in those moments. They felt it made them better doctors. But others, like Simon, expressed concern. He said, quote, "I don't want it so structured that I'm suffocating or just blindly writing an order because somebody tells me to write orders. That's not the way you learn, but I also don't want to be alone in making the decisions that I might fear," end quote. Community structure ensured that both of these extremes were happening simultaneously. Situations necessarily arose, especially late at night, where residents had to use their judgment to make clinical calls first, which, remember, they didn't have much practice doing on their own in the daytime, and inform the attending after. Now, to illustrate this, I'd like to compare two parallel examples that nicely exemplify how differences in supervision led to very different outcomes in these two places. It's also worth noting that these aren't particularly exceptional examples. The examples I'm about to give you represent more general trends at these two places. So it was around 7:30 p.m. one evening at Community Hospital when Blaine, a second-year resident, and Isabel, an intern, received 2 new admissions. One was a gentleman with chest pain. The other was a woman with possible tuberculosis, referred to as question TB. Now, after going to see the 2 new patients, they meet back on the wards where he enters orders, she updates the patient roster, and by 9:30 p.m., they finish the admissions and head home after a 14-hour shift. Now, the next morning, Blaine goes to check on the question TB patient during rounds and notices that an ultrasound technician is in the room without the proper infection precautions. Now, just as a reminder, tuberculosis is an airborne infectious disease, and so proper infection precautions involve wearing a respirator mask, a gown, and gloves to protect anybody from possible exposure to this disease. So the patient was getting an ultrasound of the heart, but that test, of course, is unnecessary for a patient with potential pulmonary tuberculosis. So Blaine starts getting this nervous laugh and says, while shutting the door, apparently she's getting a 2D echocardiogram. And as attention starts to shift to another patient, Isabel whispers to Blaine, "Did you order a 2D echo last night for the TB patient?" And he gives her a half smile and says, "I don't think so. I was really tired." So a few hours later, Blaine bumps into a fellow resident who asked him about the ultrasound. He asked, "Did you know the tech went in without a mask? Does she know it was an accidental 2D echo?" And Blaine replies curtly, he says, "Nope, and she shouldn't know." And then he jokes that it wasn't accidental, that he in fact believes that everyone should get an ultrasound of their heart at some point in their lives. He's joking, of course, but his face reveals the gravity of the situation, which is that a staff member may have inadvertently been exposed to a dangerous airborne infectious disease. Isabel starts flicking through the patient's chart and realizes that the ultrasound was for the patient with chest pain admitted the night before, not for the TB patient. Blaine ordered it by mistake, and no one caught the mistake until it was too late. So if the patient has tuberculosis, the technician was undoubtedly exposed. So this is a powerful example of how inconsistent autonomy at community hospital with its little supervision and few checks and balances could impact training and patient care. Not only did Blaine miss out on critical feedback, so his supervisors never found out about this particular incident, but an important test was delayed for a heart patient, and of course, a staff member's health was potentially put at risk. So in contrast, at University Hospital, attending physicians provided a kind of safety net for the residents, flexing their clinical autonomy even after hours. This meant that they were much more likely to catch errors before they had consequences for patient care. So in a parallel kind of story, one morning, an attending asked his intern about a new patient who had just been admitted for alcohol withdrawal, which is a potentially life-threatening condition when left untreated. So the attending asks, so he's on CWA, referring to the Clinical Institute Withdrawal Assessment, or CWA protocol for treating alcohol withdrawals. Basically, the more severe the symptoms, the more medication should be administered to avoid delirium. Except the intern forgot to input medication orders associated with the protocol. So while the patient's symptoms were being monitored by the nurses, they didn't have orders to treat those potentially deadly symptoms. So the attending continues, how's he been scoring? And the intern pauses for a moment and says, not sure. So the attending frowns and says, if you put an alcoholic on a CWA protocol, you have to give the nurses something to do other than just look at the numbers. They need to know how to treat him. So the attending says that he noticed the absence of orders last night, so he put them in for his intern. He had caught the error before it had consequences for the patient and turned it into a learning opportunity for his intern. So these two examples at community and university hospital are not meant to suggest that mistakes never fell through the cracks at university hospital or that they always did at community hospital. Rather, they illuminate how the different training approaches and attending structures in these two places could affect residency training and patient care potentially. It turns out they were both near misses. The CWA patient was treated even though the intern didn't input the orders, and the rule-out TB patient didn't end up having TB, so the ultrasound technician was fine in the end. But the key difference was in the hospital structures. Trainees are always prone to making mistakes. That's what they do, they're trainees. But at University Hospital, there were layers of supervision in place to help make sure that these mistakes didn't carry disastrous consequences for patients. At community, in contrast, the residents were comparatively on their own in a program that lacked the resources to supervise them more closely. Now, these different training approaches may have had real implications for the residents' overall medical knowledge. Remember from the outset of my talk that non-USMDs had to score much higher on step 1 to have the same probability of matching to residency compared to USMDs. Now, the non-USMD residents at community hospital were no exception, according to those who disclosed their scores to me in interviews. And those exams are pretty good predictors usually of future performance on standardized exams. However, after 3 years of inconsistent autonomy training at community hospital, the percentage of those passing their board exams, which you take after residency, was a full standard deviation below the national mean. In contrast, the percentage of those passing that same board exam at University Hospital was a half standard deviation above the national mean, which is a statistically significant difference between the two places. And again, the step 1 scores I obtained from university residents who disclosed them to me were on average lower than those that I obtained from community residents. So while causality cannot and should not be inferred from these data, the results do suggest that these different training approaches may have had real consequences for the residents' development as independent clinicians after graduation. It's worth noting that these findings reflect the broader trends from the nationwide study I referred to at the outset, where I mentioned that USMD-dominated programs have significantly higher board pass rates than IMG or DO-dominated programs. And so my hope is that my findings have helped provide some insight into why that might be. So in conclusion, I have shared with you today a very complex social story about inequality in residency training. These two hospitals were segregated along USMD and non-USMD lines. They had access to significantly different resources. They allocated those resources differently, and they had very different supervisory structures, all of which contributed to shaping the outcomes that I've described today. Unlike the supervisory practices previously described by other medical sociologists, the low level of supervision at community hospital wasn't the result of a deliberate pedagogical logic carefully titrated to the learners or even the patient's needs. Instead, it was the product of constrained time and resources, which made community residents much more like laborers than trainees. At University Hospital, there was a centralized structure with layers of supervision, which meant that residents worked with rather than for their attending physicians, making them much more like trainees than workers. Now, the findings suggest that medical education may not be as uniform as we may have thought, despite great efforts on behalf of the profession to maintain the appearance of standardization in medical education. So this might mean that we have to revisit some of the assumptions, the fundamental assumptions of professional dominance theory, which, as I mentioned at the beginning of my talk, is a theory that's mostly focused on how medicine has weathered challenges from outside of the profession. In my work, I redirect the focus to power struggles happening inside the profession. And the results I shared with you today suggest that some of those power struggles and some of their consequences, like segregation and residency training, might matter for patients as well. So I gave several examples of how this type of segregation can impact patient care in today's talk. In a separate paper that I published in 2015, I described how residents at community hospital would sometimes override elderly patient wishes at the end of life, partly because they lacked the training and the support needed to know how to ethically negotiate disagreements with their patients. So for all the emphasis on standardization in residency training, my findings show that training isn't necessarily equal between programs, and that might affect the nation's most vulnerable patients, especially since non-USMDs are more likely to go on to staff, once again, underserved and more remote areas in lower socioeconomic status populations. And finally, there are also implications for physicians. One of the consequences of such stark inequalities in training between residency programs, I find, is the maintenance of status hierarchies in medicine. In fact, the kind of inequalities in training that I presented to you today represent only one of the forces I identify in my book as contributing to a larger process that I call status separation, a social process by which those in a seemingly homogeneous profession get hierarchically differentiated by pedigree into various strata according to their social worth or their status. Now, in chemistry, separation refers to the process whereby a mixture is reduced to its component parts, either through the application of external forces, like in the case of centrifuge, or via natural processes like gravity separating oil and water, for example. In this book, I tease out the social forces that push USMDs to the top of the status hierarchy and push non-USMDs to the bottom of the status hierarchy, thereby separating them in status according to pedigree. And the colloquialism, the cream of the crop, is often used to describe the best of a group. And meritocracy, or an individual's hard work, intelligence, and dedication, is often assumed to be the process that separates out the elite from the rest. In my book, I problematize this assumption by showing how structural forces, like institutional inequalities in resources and in training, lead to this kind of stratification in medicine. Today, I've had the opportunity to tell you about just part of those forces, but in the book, I broadly find that broader class inequality, professional sponsorship, status beliefs, bias, and stigma, structural inequality in training, and eventual differences in merit resulting from those structural inequalities in training help contribute to status separation in the medical profession. So I'd be happy to talk more about any of these processes or anything else you'd like to in the Q&A, but for now I'm going to thank you all for your wonderful attention, and I look forward to answering any questions you might have.
Excellent. Thank you so much for that. Just a quick reminder to folks to please drop your questions for Dr. Jenkins into the chat. That way Megan can relay those questions in the most efficient way possible. So it looks like we've at least got one in so far, but we'll give folks a moment, or we can start with that question while folks type up their question.
All right, so our first question is from Dr. Threlkill. Dr. Jenkins, it's interesting to relate your fascinating sociological analysis to psychological theories. Regarding the autonomy structure of University Hospital, it sounds a lot like D.W. Winnicott's conceptions of 1, a good enough parent, and 2, a holding environment. These elements, Winnicott argues, lead to healthy identity formation, versus community hospital, which would be akin to 1, a not good enough parent, and 2, the lack of a holding environment, which leads to problems in identity formation and autonomy, etc. I wonder if you have also thought about this analogy. Of course, residents are not children.
Right, they're not children, and yet they are undergoing quite intensive processes of socialization, which is where there is that very real parallel between children and trainees of this kind. I'm not familiar with this, this idea, but I think it's really, really interesting. And I think part of what I do in my research is trying to understand how the training environment produces different kinds of physicians. I shared with you today findings from primarily from chapter 3 of the book that looks at the formal medical curriculum. The 4th chapter of the book actually looks at the more informal, maybe what some might call the hidden curriculum in these 2 programs, and looks at how actually the chapter is called grooming. And so how residents in these 2 places are groomed entirely differently, and how that actually has impacts on their professionalism during residency. Also, I examine how it impacts their mobility in terms of their ability to go on to subspecialize in the profession, for example. But it's something that I'm fascinated by, is how these training environments can produce very different kinds of trainees, leading to some of the status hierarchies that I've pointed to. So thank you, Professor Threlkill, for that question. And I'll give it some more thought.
So our next question asks if you explored other factors that may be related to status separation, such as gender.
Yes, a great sociological question from one of my favorite sociologists at UNC. Yes, so of course there are other processes at play. Gender is definitely part of that process. Race is definitely part of that process. I refer to class primarily in my findings. In my own research, I did not find sort of really obvious patterns of gender inequality or gender, certainly no gender segregation. It was part of the reason why I chose internal medicine as the specialty of focus. It's actually a specialty that has more or less equal numbers of male and female residents. There were certainly differences in how male or female applicants were sometimes evaluated. There is a particular instance that I'm thinking of at University Hospital where there was a discussion during the resident selection committee process about a particular candidate who had a criminal record. And but it was something sort of back in their past, and it was kind of shrugged off as you know, something that, you know, maybe someone younger would do. And I think the comment, I'm not going to get it exactly accurate, but I think the comment was, oh, I'm sure his male prefrontal cortex has had a chance to develop, right? And so it's really interesting how applicants would be gendered in this way, and sort of how expectations would be gendered in different capacities. I know that Judith Lorber has done a lot of work within sociology looking at inequalities among physicians of different genders. And her findings from the 1980s bear a striking resemblance to my findings in the 2010s. She also finds processes of sponsorship within the profession, whereby male physicians would often be kind of taken under the wing of another physician and maybe sort of, sponsored through the training process and encouraged in that way. And I found actually quite similar processes happening with USMDs more broadly. And so my work is very much in conversation with Lorber's work in that regard.
Spencer Tackett says, thank you so much, Dr. Jenkins. Can you talk a little more about this phenomenon in relation to end-of-life care?
Yeah, so this is sort of tying back to, as I mentioned, a piece I published about 5 years ago at this point. But I think part of the question that I was looking at end-of-life care is why is it that in an age of patient self-determination, right, which is actually the law, it's been enshrined in the law since 1991 that patients have a right to a say at the end of life. How come it's so common that physicians still make decisions at the end of life that don't reflect their patient wishes? There was a massive study, and now I'm forgetting the acronym, but that found a very consistent difference between what patients' stated wishes were and what physicians ended up doing at the end. And so in this particular paper, I used community hospital as a kind of case study for trying to get at why this is the case. And I actually ultimately found that I think that the trainees at community hospital, were not given, much like what I presented today, were not given the support or the training they needed to really know how to ethically engage with their patients, right? They were caught between, on the one hand, respecting patient autonomy, but on the other hand, feeling very, very strongly that they had to do what was in their patient's best interest and not harm their patients. And so they were finding themselves being pulled sometimes between what their patient wanted them to do and what they thought would actually end up being tantamount to harming their patient, which would be a violation of a lot of the ethical codes that they had sworn to in the Hippocratic Oath and other such professional rituals. And so, so they resolved that largely without the help of their attendings. They would often resolve it kind of more informally, either by very aggressively sometimes trying to change their patients' minds, or in a handful of cases, taking the decision upon themselves and engaging in what's been described in the literature as a soft code or a slow code. Usually the discrepancy was a patient wanted heroic measures to be undertaken at the end of life, and the house staff felt very strongly that that would be actually harmful to the patient. And so in certain extreme circumstances where there was just no possibility of bridging that gap between physician and patient, there were cases where at least residents talked about not either walking, not running to a situation where someone's heart is stopping and their lungs are no longer working, or chest compressions to be effective have to compress the sternum a full 2 inches. And so it's relatively inconspicuous to be doing chest compressions that are not effective as a way of resolving this ethical dilemma that they were faced with. And I think if I'm tying this back to what I presented today, I saw very different patterns happening at University Hospital, where there were role models there, where physicians could actually observe, the residents could observe their seniors having these difficult conversations with patients. But they really had the support needed to be able to navigate these professional dilemmas in a way that community hospital residents just didn't.
I'm going to just briefly interject to note that we're right at that 4:30 mark, and I know many people who have joined us today have to move on to the next thing. So I just want to interject to say you're welcome to log off if you're heading to the next thing. But Dr. Jenkins is gracious enough to stick around for a few more minutes to take 1 or 2 more questions.
Very happy to.
Well, thank you. So our next question says, based on these conclusions, I'm sure there are a large variety of changes that could be made to ameliorate such disparities. Do you have any insight as to which changes may be most important to focus on? Also, who do you think / what types of professionals can make the changes necessary to address these disparities?
Yeah, those are excellent questions about not only what has to change, but who's in charge of changing it, right? It's kind of an elusive question. And you know, I think I'll answer the second question first. I think, you know, medicine is often studied by sociologists because it's kind of the quintessential profession. It's a profession that has more autonomy maybe than any other profession. And what I mean by that is that physicians are the ones who largely set standards, and they're the ones who largely are involved in implementing those standards and educating future generations of physicians. And so the types of professionals needed to make these changes, I think, are actually other physicians, in part because the medical profession has been very successful over the last 100-some years at actually pushing back against other social actors and forces trying to impinge upon the profession's inner workings. So that's who would have to be convinced of that a change is needed. In terms of what is needed, boy, I think at a minimum, I think a recognition that even though there are standards in place, those standards don't necessarily imply equality across training programs is really key. Let me be clear that community hospital, for all of its drawbacks, was very much an accredited program. It was in good standing with the Accreditation Council for Graduate Medical Education. It checked off all the boxes for what was required to be an operational residency program. And yet, there were some of the deficiencies in training that I observed. And so I think already what needs to change is at least an acknowledgement that standards are good, they're important, but they don't necessarily mean that training is actually standardized, or that residents are actually getting the kind of training that they need. I think that's number one. And number two, I would say that, I think programs like Community, there are many programs like Community, some of which are even smaller and have fewer resources. Others are larger and have more resources. But they serve a really important role in the country. They serve underserved communities. They're serving geriatric communities oftentimes. And so I think there needs to be a recognition of the importance of these programs and an infusion of resources to make sure that that there is a basic modicum of training that's happening. And I think that the main thing that I would recommend doing, if I could make a recommendation to community hospital, would be to replace this community attending model where physicians are in the community admitting their own patients and having very little contact with the resident staff. To be sure, there were daily teaching rounds, there were educators that were around, but oftentimes those educators weren't the same physicians that were actually in charge of the patients that were admitted to those residents. And so there was very little in the way of, there was very little opportunity for those educators to actually make any changes to the treatment plan or actually sort of make relevant suggestions. So I think one thing that really needs to change is that particular model of training. I think if hospitals could all have the kind of model where there are hospital-based physicians on staff supervising physicians regularly, I think that could be a big benefit.
All right, well, Kim asks, in our class discussion about your book, some of us were wondering what role xenophobia or anti-immigration rhetoric might play in the stratification that you've identified, especially when it comes to the placement of non-US citizens in these residency programs.
That is a great question, and I'm actually going to, I just unshared my screen, but if you'll indulge me, I'd like to share the screen again just to give you a sense of what this looks like. Yes, so there is most certainly xenophobia happening in the process of residency recruitment in particular. I want to share with you, this is again, a tiny bit of a long quote, but you'll see why I think it's really, it really captures some of this ethos. So there would often be veiled references to the risk of unprofessional conduct as being a reason or rationale for why large programs like University Hospital would be less likely to recruit international medical graduates, specifically non-US citizen international medical graduates. So these are the types of risks that would be invoked when I would ask decision makers, why are there no international medical graduates on the House staff? And so this would be the answer. For example, I'm going to refrain from saying those people, but they come out of societies oftentimes in cultures that are so hierarchical, that are so male dominated and oppressive. A lot of the better higher up residency programs view them as just not retrainable. They're very fixed in their ways. A lot of them are incredibly bright, but don't speak up. They mumble, their English is crappy. They're not sexist, but they genuinely think that women should be subservient. They don't think about the end of life in the same nuanced way or think patients should make any decisions. Yeah, it's crazy the degree to which sometimes those guys are living out the stereotype. They must come over to interview in the US, but boy, sometimes it's just like, these people are there. I said it. I didn't want to say it. I didn't want to say these people. That was one faculty member, and another administrator for the program said something similar, quote, people are from countries where gay people are killed. I don't think I can afford to have someone who's incredibly narrow-minded on the House staff. So that's one of the risks. And so I think xenophobia did play an important role, and I think it was used, hidden, shrouded by terminology that was really rooted in risks to patient care, when in fact, I think what was really underlying was racism and xenophobia. And so I think it definitely played a role. And something I was really struck by was how all international medical graduates, regardless of where they were from, were characterized in this way. There was no attempt to kind of differentiate between them. Foreign was foreign at University Hospital.
I think playing into kind of those observations about the role that race plays in that stratification, Dr. Threlkill comments, when physicians began to get COVID and even die in March and early April, I thought, now it has reached elite circles, maybe we will take national action. Then when photos of clinicians who died were shown, I noted with dismay how many were people of color, likely international MDs and other who were in the community hospital class.
Yeah, we're definitely seeing, I think COVID more broadly has brought to light some of the broader underlying inequalities that have long been there, but that are now sort of becoming thrown into sharp relief because of this pandemic. It's actually the topic of my next research project. I'll be starting fieldwork very shortly to understand how the COVID pandemic is shaping physician mental well-being, and trying to kind of better understand the broader burnout epidemic among physicians that long predates COVID. One of the surprising findings from my book was that for all that they were much higher status than non-US MDs, the US grads in my sample were quite disillusioned. They had many more opportunities than non-US MDs did. They were higher status in this training program, but some of them regretted going to medical school. A lot of them referred to it as the $1 million mistake. They were quoting an article that was going around social media at the time by that same title. And so that left me puzzled. Why are so many physicians so disillusioned within medicine? And that finding actually has been replicated at the national level, such that international medical graduates are less likely to be burnt out than US MDs. And so this next project is going to be exploring a little bit more about how that's the case.
So since we're past time and we're getting more informal, I turned on my mic. Tanya, with respect to that, I wonder if we might put the quotation that you showed prior next to that observation that you just made to say, I don't know if Austin is still on this call. He's a medical student in the matching phase. But it seems to me the medical students I talk with are just painfully, acutely, agonizingly aware of their affective role. So in the olden days, the role was patients do what you tell them. There's a hierarchy, the nurses are below you, you know where you are, you know what your authority is. I'm just reeling out stereotypes, of course, but today's medical students, at least at UNC Chapel Hill at university, they know that a huge part of what they do has to do with things like extension of empathy, ushering people through complex end-of-life care. I mean, none of that is, give me a line. None of that is sort of the high action ER drama stuff. So they are affective laborers as much as kindergarten teachers, as much as, social workers. And, maybe kindergarten teachers and social workers are better trained in those interpersonal, complex affective processes. Don't you think?
I think this is fascinating. I mentioned a little while ago that one of my research interests is professional socialization. So how trainees are taught what it means to be a good doctor. Mm-hmm. And one of the pieces that I'm really interested in studying in this new research is, what does it mean to be a good doctor from an emotional perspective? What is expected of physicians emotionally? Yep. And how does that relate to burnout? And one of the expectations I'm particularly fascinated by is the expectation of never showing weakness, right? What I call the superhero norm of always keeping it together, not showing that you're struggling, always outperforming one's peers. And I'm particularly interested in this new study of mapping out how that expectation gets communicated, how it gets inculcated into trainees, and how it gets internalized, and then what happens when it gets transgressed, right? And I'm thinking about this from a life course perspective, thinking that this norm probably starts actually before medical school, among pre-meds, right? The idea of having to outperform one's peers and never show weakness and be on top of things. And so this next project is actually going to be looking at pre-meds all the way up to attending physicians to see how this process of professional socialization works across the life course.
Yeah, Dr. Jenkins, if I can jump in for a second, I think there is so much to unpack there. The emotional labor of the medical student is extensive and expected. Because we are not the resident, we have all this free time, which is supposed to be spent studying for our own mini board exams, but then we're the ones who are sent into the patient's room to have these extensive conversations and to be, I don't know, to be the doctors that the residents can't always be, because they're carrying 15 patients, have to do all the scut work, have to manage everything, have to put in all the orders. So the medical student is kind of the perfect person to go in and, go have this very intimate conversation with a stranger who's dying, and then come back and report. And then you're going to do that later, and then you're going to go home and study all night. And then you're going to come back and struggle through rounds in the morning, and do that 6 days a week. And you're right, that mentality started back in when I was an undergrad, and I went straight through. So I didn't really have a break to kind of get a breather, but just the immense competition they get into medical school kind of instills this mindset that you have to be perfect, you can't show weakness, that you have to give and give and give. And then one day you'll get something back, but that day's far off, and you just have to put in the work and suffer the people before you did. And I know I could probably spiral here into a long rant about how medical school has been, but a lot of the things you said very much resonated with me in my experience.
Yeah, thanks for sharing that. I think it is striking, and at least in my fieldwork for this book, something that struck me was a kind of inverse care law, where the lower you are on the medical hierarchy, the more time you actually spend with patients, right? And so there is this way in which medical students are actually spending a lot of time, but are expected to do a lot of emotional labor to have that conversation, be empathetic, and then turn around and give a 30-second summary to the resident, and then move on to the next patient and do it all, right? I saw somewhere in the chat that the superhero norm is something maybe more broadly applicable to American society. And one of the things I'm interested in exploring is how societal expectations of physicians are also an important factor. And that's something that is changing or maybe becoming more pronounced during COVID. And so all of the healthcare heroes type signaling has been really fascinating to me, because I think there's already an expectation of being a superhero within the medical profession. And now it's being articulated by society that this expectation is very much, is very tangible and very kind of, being re-articulated over and over again. And so, I think there has been a lot of research recently on COVID and on burnout, and a lot of it's really important, but so much of research on burnout has focused on the individual and on their individual predispositions to burning out, different characteristics that might make them more or less resilient. And as a sociologist, my lens is always, to of course consider the individual factors, but to also consider the structural factors, the professional, institutional, and societal level factors that may be shaping this outcome.
Well, I look forward to having you back for another Grand Rounds presentation when you have the results of that new ethnographic fieldwork ready to present to us. Hopefully you'll put us at the top of your list to come share that with us. Because it just such wonderful work and incredibly important. And I know many of our students are invested in and concerned about what their experience of this profession might be. And burnout is up there among those concerns. So really looking forward to that work. I just want to thank you one last time for joining us this afternoon, and everyone else who stuck around after our official and unofficial stop time. And if everyone will humor me for just one more moment, I just want to quickly plug our next speaker, Dr. Ann Lyerly, who is a professor in the social medicine department and the associate director of the Center for Bioethics, who will be talking about some of the research that she's been doing on decisions about whether and under what circumstances to become a parent in relation to some of these broader public concerns. So she's thinking about COVID and pregnancy decisions in this context. So she'll be joining us on Thursday, November 10th at 12 p.m. So you can always join our mailing list to find out more about these talks coming up. So thank you for being here this evening. Thank you again to Dr. Jenkins. We really appreciate you being here. I hope everyone takes good care.
Thank you so much for this opportunity. I had a blast, and yes, thank you so much. And I look forward to being back hopefully soon with new results.
Agreed. All right, everyone, have a great evening. Thanks again.